It's very difficult to talk after Balavikat sir has talked. So, dear sir, we are afraid of something like medical legal things, bleeding, and medical legal things and bleeding. If the bleeding occurs in a very close space, like intracranial, intraocular, or in the epidural space, a small bleeding can cause a lot of problems. So, do you still believe that we should be giving anticoagulants and then giving epidurals? Why this anticoagulants and antiplatelet problem has come? This basically come because of increasing number of intravascular stents, intravascular devices which the people are putting, and also because of the age, gender which is increasing. The antiplatelets, anticoagulants, thrombolytics cause a lot of big challenge for anesthesiologists, and we have to balance between the patient care and the risk which is involved. That is the risk versus benefits. What is spinal epidural hematomas? Spinal epidural hematoma is the accumulation of blood in the potential space between dura and the bone. Hemorrhage into the spinal canal commonly occurs in the epidural space, and prominent epidural venous plexus are there which can bleed. They don't have any binding material or binding fibers which can stop the bleeding like we have in the skin. It may be spontaneous also, or it can be because of minor trauma or lumbar puncture, and mainly because of epidural catheters, indwelling catheters. While removing the catheters also it can cause. It is more likely to occur in anticoagulated patients. So, we increase the risk by giving anticoagulation. So, what is the incidence of this? Okay, for epidural it is 1 in 1,50,000. For spinal it is 1 in 2,20,000. But in an anticoagulated patient, the risk increases to 1 in 3,000 for epidurals and 1 in 36,000 for spinal. There are multiple papers which had come about epidural hematoma. If you can see the marked part, that is the highlighted part, you can see epidural catheter. While removing, the patient had hematoma. In the other one, where there was an elevated EPTT, partial thromboplastin time, and PT, the patient had epidural hematoma. There are multiple papers in literature which show us that these anticoagulate patients had bleeding in the epidural space. In one of the journals, it has come that severe complications such as spinal epidural hematoma and an array of adverse neurological events lead to temporary or permanent disability and have been ascribed as central neuroaxial blocks. What are the different factors which are responsible for this? Of all the other factors, one of the main factors is using of low molecular heparin in an immediate preoperative and postoperative period. Early postoperative low molecular heparin, if you have a dual antiplatelet therapy which goes on with all the intravascular devices and stents, and a twice daily low molecular heparin. Most of the patients who don't have intravascular devices, they can also be put on anticoagulants. They are like the patients who had a trauma, cancer patients, the patients who are at a risk of thromboembolism, and pregnancy. Pregnancy is a hypercoagulable state. So, most of these or some of these patients are put on anticoagulants. They are put on antiplatelets like ecosprin. The dose of ecosprin of 75 to 150 milligram is no problem, but if they have a higher dose like 325 milligram, yeah, there is some concern. We all practice good amount of labor analgesia. So, if these patients are anticoagulated, they have engorged epidural vessels. If you pass a catheter in these patients, it has a higher chances of bleeding, and this bleeding won't stop immediately because they are anticoagulated. Different types of antiplatelets which are available, which we all know, out of which the common ones are aspirin, clopidogrel, ticlopidin, Tyrofeban and Tyrofeban group, that is GP2B3A inhibitors, which are short acting. They can be used for a bridging therapy, which sir was telling. These drugs, if you want to change or do a bridging therapy before surgery, these drugs can be used. Then antithrombotic drugs like heparin, then fundoparaxin or low molecular heparin. Vitamin K antagonists like warfarin oral, which was given to most of these patients with VTE. Platelet aggregation inhibitors that like clopidogrel and vitamin K antagonist. This vitamin K is responsible for factor 2, 7, 9 and 10, and normalization of INR, that is INR of less than 1.4. If you want to do in these anticoagulated patients, we have to give vitamin K, or in a patient where we want to take him for surgery in a time before the INR comes back to 1.4, you have to use fresh frozen plasma. Again, using fresh frozen plasma, you are introducing blood products which are a higher risk, and the higher risk of giving these proteins. So what we have now? We have IV heparin, where the APTT is raised, and it has an immediate effect and lasts for around 4 to 6 hours. Giving low molecular heparin once daily can last for 24 hours, or some low molecular heparin are available which are given BD, that is twice daily, which lasts for around 12 hours. Warfarin lasts for around 4 to 6 days after you stop the doses. So we have to wait for the action to come down. We have to wait for the INR to reach normal. Ecosprin 5 to 8 days, and clopidogrel and ticlopidine take around 5 to 14 days sometimes for its effect to wear off. How do these patients present? That is very important, because if you don't take a rapid action, there are big problems which can occur. These patients will present as severe localized constant back pain with or without radicular component, and it mimics a disc prolapse. There will be weakness, numbness, increasing in the paresthesia, urinary or fecal incontinence, and after your spinal or epidural action has worn off, you have shown that the leg is moving, and later on after 8 hours again the patient starts getting numbness, again the patient starts getting paresthesia or decrease in sensation. You should have a ringing bell in your head. Clinically, there is a progressive neural deficit. As you can see in the picture, there is a huge epidural hematoma which has occurred, and this has compressed the spinal cord. If you want to diagnose it, we have to be very fast, have a very high index of suspicion, and radiologically with the use of MRI or even ultrasound we can diagnose it. But your action has to be very fast, because if you treat these patients within 8 hours, the chances of their recovery or neural damage recovery is better than if you go beyond 24 hours. If you can see this chart, if it is less than 8 hours, most of the patients recovered well. But as the time progressed, as the neural damage progressed, the recovery was very slow. In cases of heparin, if you compare, if the patient is not receiving any heparin, the risk is for spinal is 1 in 2,20,000, and if he is using heparin, the risk comes down to 1 in 70,000. In this paper which has been published by Stanford Smith, if you are using dual antiplatelet therapy, that will be with the ecosprin, the risk of having a hematoma or bleeding comes to 1 in 8,500 for epidurals. Heparin, there are many cases which were reported by the MedWatch, 40 to 60 cases, and these are the different associations like German Association, Belgium Association, which had shown different regimes. So what do we, if the patient is on warfarin, we have to stop it for 5 to 7 days and let the INR come back to 1.4. You have to discontinue clopidogrel 5 to 7 days or prasugrel 7 days before. There are different recommendations which have been given. That means you have to go by your clinical judgment. Low mercury heparin or unfractionated heparin has to be stopped. Warfarin has to be stopped. Aspirin, as we told earlier. For regional anesthesia, the platelet count has to be more than 50, and for epidural, it has to be more than 80,000. So knowledge of pharmacology and pharmacokinetics and dynamics will allow practitioners to anticipate difficulties and expected complications. In case of anticipated risk of bleeding, why go for it? Just avoid it. You can go for other techniques. All anesthesia techniques are good. Rapid diagnosis and intervention is the crux of this treatment. Thank you.